Go ahead, Dr. Puneet.
Good evening, friends. Greetings from Uttarakhand. In continuation with our webinar series, today we will discuss a few topics related to osteoarthritis knee and replacement surgery. Today we are having our guest faculty, Dr. Ravi Mittal sir, Professor in AIIMS New Delhi, Dr. CS Yadav sir from Primus Hospital New Delhi, and Dr. R.B. Kalia sir from Associate Professor AIIMS Rishikesh. So without delaying, I would like to invite Dr. Ravi Mittal sir. His topic is HTO in osteoarthritis knee, precautions to be taken. Hand it over to Dr. Ravi Mittal sir. Ravi sir, please share your screen.
Can you see that?
No, sir.
Yes. Is it visible now?
Yes, sir. Just enlarge your, sir. Yeah, it's fine, sir.
Good evening. Thank you very much for inviting me to speak on high tibial osteotomy. Now, once you diagnose osteoarthritis of knee, you can start with activity modification, weight loss, physiotherapy. You can add medicines like paracetamol, non-steroidal anti-inflammatory drugs, opioids, or you can inject some hyaluronic acid or PRP in the joint. If all these don't work, you are left with the surgical option of arthroscopy, high tibial osteotomy, and replacement. Replacement could be unicondylar or total knee replacement. Arthroscopy has a very limited role now. Nobody does arthroscopy for osteoarthritis of knee today. So how do we select the treatment for this? We start with non-operative, go to injections, and then surgery. Now, knee replacement is very popular. It is widely and aggressively marketed by the companies, the hospitals, and the doctors. And patients come and demand this procedure. And surgeons go out and sell this procedure. But what is not told about knee replacement is that man cannot become God. There is a limited longevity about these implants, average 20 years. Some people claim more, but on an average, it's around 20 years. But at the same time, it imposes many physical restrictions for the patient, and there is an altered lifestyle for the patient, especially when he cannot sit on ground, cannot squat, cannot sit cross-legged. With the increasing age of the Asians, the problem is, would the implant outlive the life of the patient? Ideally, the implant should outlive the patient. And it is possible if done after the age of 60 to 65 years. And if it is done earlier, the patient would require a revision surgery. The physical restriction imposed by the joint replacement surgery is that the patient cannot squat, cannot sit cross-legged, and running and sports are preferably avoided by the patient. And sometimes the patient resists changing the altered lifestyle. They cannot sit cross-legged for puja or sajda for namaz, cannot sit on floor during various social gatherings. Professional like gardening, farming have to be abandoned. And in a city, the patient cannot run after the bus or the train. So these are the limitations which is imposed by the lifestyle, and they are usually not talked about. So who is best suited for TKR? He's an elderly patient, more than 60 to 65 years. And in this patient has a bicompartment or a tricompartment disease, which is late stage, and all the non-operative measures have failed. But if the patient is less than 60 to 65 years and is a unicompartment disease in the medial compartment and non-operative measures have failed, what to do? The answer is HTO. So what's HTO? That we shift the mechanical axis from medial compartment to the lateral. And how much to shift? That the weight bearing axis should pass through the Fujisawa point, which is around 63% of the tibial plateau width. And accuracy determines the clinical outcome. Overcorrection or undercorrection will produce bad results. In a classical teaching, the prerequisites for HTO in osteoarthritis is age less than 60, varus less than 15, pure medial OA, and metaphyseal varus. But these indications are now stretched. Contraindication is bicompartment or tricompartment disease, isolated lateral osteoarthritis, varus more than 15, flexion contraction more than 10 degrees, range of motion less than 90 degrees, bone loss and subluxation more than 1 centimeter. You can do HTO for other indications also, like man unions after trauma or surgery, developmental deformities, and instability due to cruciate injury, where you can change the slope. So how does it work? It has both a mechanical effect and a biological effect. Mechanical axis is shifted from the medial to the lateral compartment, unloading the medial compartment, and hence the pain is relieved on the medial side. It decompresses the medullary hypertension and relieves the pain on the medial side. But the bottom line is the surgery has to be accurate. At the end of the surgery, the mechanical axis has to pass through the Fujisawa point. So HTO provides good pain relief. It does not imposes any restriction of activities or changes lifestyle. It was very cheap as compared to TKR in the olden days, but now the cost of the TKR has become down. The difference is lesser, but still cheaper, and is more suited for the Indian condition where the patients like to sit on ground, they like to squat and sit cross-legged. So is HTO a new procedure? No, it's an old procedure. It is even older than the TKR. Then why are we talking about it? Because we would like to re-emphasize that TKR is not suitable for everybody. HTO is a good option in medial OA in less than 60 to 65 years. And now that we have a newer implants, the surgery has become much easier and reproducible. The types of HTO could be a closed wedge, open wedge, or a dome osteotomy. In the closed wedge osteotomy, we remove a lateral based wedge, and the gap is closed with minimal implants or no implants. You can use a simple staple or a K-wire also, and then a plaster is given. The objections against the closed wedge HTO is that you are stuck with the wedge removed. So there are chances of under and overcorrection. Fibula osteotomy is required, and the shape of the proximal tibia changes. The truncation of the proximal tibia, and early mobilization is difficult because you're giving a plaster. But the bottom line is the functional results are good. So these problems have been overcome by open wedge HTO. Now the accurate correction is possible because you can titrate the angle looking at the mechanical axis. No fibula osteotomy is required. There is no truncation of proximal tibia, and early mobilization is possible because you're putting an implant. And why this is possible? Because now the availability of the pre-contoured angle stable implants are available. Different kinds of implants are there. They provide good initial stability, and the stability is maintained till the osteotomy is healed. So this is an example of a 30-year-old female. She had bilateral knee osteoarthritis with tibia vara, failed medical treatment, range of motion was 0 to 125, and we did a HTO, and patient had a good result. This is a bilateral medial compartment osteoarthritis in a 50-year-old OBG doctor. She underwent left side HTO as a trial because everybody was advising knee replacement, but she just went for a trial and came back for the right side when she was happy. And she continues to maintain this. It's more than 20 years that we did it, and she's still happy with this result. This is bilateral OA knee. Patient was unable to walk more than half a kilometer. Medical treatment had failed. Range of motion was 0 to 110 degrees. And on the patient request, we did a bilateral simultaneous HTO at the same setting. This was post-traumatic unilateral medial compartment osteoarthritis, 40-year-old female, had a limited walking, had a ipsilateral shaft of femur fracture, which was operated, and now had a severe bone-on-bone medial compartment osteoarthritis, for which we did a HTO. And the patient could even dance after the surgery in a marriage. This is a 65-year-old male who is a national level hockey player, had an old injury to the right knee, a failed conservative treatment was there, and he wanted to preserve his knee, and he was a smoker. We did this surgery quite recently and is pretty happy after the surgery. No pain, no analgesics required, full range of motion, can walk around more than 3 kilometers. But there are many controversies and concerns which are raised. Some are genuine and some are artificially created. So we'll discuss one by one. They say HTO is an abandoned surgery. The answer is no. Because of the Walmart approach of the doctor doesn't advise this HTO to the surgeon. He just advises knee replacement. Now, what is Walmart-like approach? In a supermarket, the company wants to sell something very fast and early. So they put it in the path where the people walk. So they can see everything very easily. They put everything at the eye level. Something they don't want to sell, they put it above the eye level or below the eye level. So similar thing is there. The doctor will talk about the surgery which he wants to perform and sell. He'll not talk about the surgery if he doesn't want to do or sell to the patient. Another argument is HTO is a procedure for underdeveloped region. Now, this belief came about because the patents of all the implants for knee replacement are with the Americans or the British, and we usually listen to them. And since it is market driven, we think that what the Americans and British are doing, that's the best. And the HTO is only for the people who can't afford this kind of surgery or don't know how to do this surgery. Their social customs are very different as compared to ours. So they don't have to sit on ground and squat and sit cross-legged. But if you see the rich nations in Asia and Europe, like Germany, France, Japan, Korea, the people are rich, but they do HTO. Their literature is not in English, and at times we are not aware about what they are doing. Other concern it will cause a lateral OA because we are shifting the mechanical axis laterally. The answer is no. It took about 50 years to develop medial compartment osteoarthritis. So it will take another 50 years to develop lateral compartment osteoarthritis. And by the time the patient would have lived his whole life. Another big myth which is spread is that HTO is not good for complete cartilage loss, which is called a bone-on-bone or kissing lesion. Now, people have shown very elaborately that when they do HTO in a case which has bone-on-bone lesions, like this is pre-op and post-op, they have shown that the results are good, functional results are good, and even the cartilage regenerates in the compartment where the cartilage was absent after the surgery. This is another report from Korea, which says that the good HTO is a good alternative to UKR for medial osteoarthritis with kissing lesions. Another report from Korea again, that they performed HTO in 2 groups, one with kissing lesion and without kissing lesion, and both groups had favorable short-term and clinical and radiographic outcomes. And the inference was that the HTO is a good option for osteoarthritis with kissing lesions. Another myth is that this is a stopgap arrangement. It will fail after some time and then you will require a knee replacement. So our argument is, strictly speaking, it is yes, a stopgap arrangement because nothing lasts forever. But the same is true for TKR and UKR also. They don't last forever. But nobody asked this question for TKR and UKR. And the time gap is long enough when done accurately, and it is long enough to avoid TKR later. So these are the survivorship of HTO. This is the Koshino, the same author, who had showed that the medial cartilage regenerates. He says that the 97 survival rate at 7 years, 95 at 10 years, 87 around 87 at 15 years. Another report, 97% at 10 years, 90% at 15 years. Another report, 94 at 5 years, around 80 at 10 years, 65 at 15 years, 54 at 18 years. This is 65 to 74% at 10 years. So HTO has a long survivorship. It's not a simple stopgap arrangement which will fail in a very short duration. This is long-term results which show that survival rate of HTO is 95% at 12 years after the procedure. They have done sort of a review that the survival rate is 99% at 5 years, 94 at 10 years, and around 85 at 15 years. Another report, 15-year survival for closed wedge osteotomy was 92.5% at 15 years. So the survival is good. And in addition, they found that the health-related quality of life was nearly as high as in general population, because these patients did not have any restriction of activities or precautions to be performed. Another report in 2020, 5-year survival rate ranges between 86 to 100%, 10-year survival rate 64 to 97%, 15-year 44 to 93%, 20, 46 to 85%. Now, what they found was that the improvement continued to be there till final follow-up, and they concluded that the need for arthroplasty could be delayed for more than 15 years in majority of the patients. Another argument is that it did not give a good result to my patients. It could be because of poor case selection and improper technique. Poor case selection means that it was done for some inflammatory or bone defect, in presence of fist flexion deformity or decreased range of motion, in presence of ligament laxity, or when the patient had bi or tri-compartment osteoarthritis. Undercorrection, overcorrection, and when the osteotomy is not done at the cora would not go to results. So it is mandatory to check the mechanical axis intraoperatively by any means, either using image intensifier or navigation. And there should be some liberal use of intraoperative monitoring of the mechanical axis. Another argument is it compromises future TKR. The answer is again no. There is no difference between TKR and TKR after HTO. Multiple reports are there. On the contrary, TKR is easier when deformity is not to be corrected. Another argument is that HTO is not suitable in old age. You saw we performed one surgery in patient who is 65. Literature also says that the age of the patient does not have to be taken into consideration for indication for high tibial osteotomy. This report in 2017 shows that the that the age did not influence the clinical and radiological outcome after open wedge HTO, and they compared the two groups which were less than 65 and more than 65, and there was no difference between the two groups. Another study which had two groups in less than 64 and more than 65 age patients, and they found there was no significant difference in the survival rates of HTO between the two groups. So you can do it for elderly patients also. So can you compare HTO with TKR? Actually, you cannot, because you have different sets of patients. This is monocompartment osteoarthritis in the medial side, which is suitable for HTO. The picture on the right is a tri-compartment or bicompartment disease. It's not suitable for HTO, it is suitable for TKR. So if you have a medial compartment osteoarthritis and you do a TKR, what will happen? It amounts to overkill. It will require revision because it is early in the age of the patient. It will impose lifestyle alterations and physical restriction for the patient when he's still, say, in his 50s or 60s. So that will compromise his functions and lifestyle. I could find one study which compared HTO with total knee replacement in a medial compartment osteoarthritis, and they found there was no difference between HTO and TKR. But the problem is HTO versus UKR. You have overlapping set of patients and you have to decide for that particular patient what to do. So the decision to do whether to do STO or UKR would depend on your knowledge, which depends on the understanding of the problem and finding a rational solution. And that depends on what you see and read. So who is the author, who is the, from where he's working, and what is his financial interest in the report, and also what your colleagues are doing in and around the city or in the country. So I'll give an example. If you have a car and its tires have asymmetric wearing out, either the inside or the outside, what do? You do a realignment of the tires. You do a balancing of the tire, or you check the alignment, and that's similar to osteotomy. You don't change the tires. Changing a tire is something like TKR or UKR. UKR never corrects the alignment completely. You just put metal and plastic in a varus knee, and those things are bearing more than 60% of the weight of the body. This is a meta-analysis and systemic review, and this report came in 2017. It was unable to conclude whether the UKR is better or STO is better. Report from Journal of Arthroplasty, meta-analysis. They say there is no difference in the specific knee scores between STO and UKR. There is no difference in the complication rates and rates of revision. On the contrary, range of motion is better in STO. Another report in Journal of Arthroplasty, it says there is no difference between UKR and STO in return to recreational activities and short-term clinical outcomes. Another report, no difference in the long-term survival of STO and UKR. The failure in STO because of the progression of the medial compartment osteoarthritis, where the failure in the UKR in the long term is because of femoral component loosening. Cochrane database, it says there is no difference in the pain, function, and gait between the two procedures. Another report, STO is comparable to UKR in terms of clinical outcome, and STO is a good alternative to UKR for medial compartment osteoarthritis, even in presence of kissing lesions. Another report, no difference at 12 and 24 months between the two procedures. STO has better correction of mechanical access. In STO is the treatment of choice for younger and active patients. Now, I could find one report which says that the UKR has better durability and higher activity than STO. But if you read between the lines, the authors had some financial disclosures. They had some financial relation with the procedure. That is why they said that the UKR is better. But even this concluded that UKR had earlier revision to TKR as compared to STO. This is systematic review and meta-analysis. In Journal of Arthroplasty, no difference in functional results, no difference in survival. On the contrary, STO has better outcome. Australia and New Zealand registry, it says that there's 18% revision of UKR at 12 years because of loosening and lysis, and revision rate is highest in younger patients. When you convert UKR to TKR, the surgery is difficult and the results are inferior. Whereas when you convert STO to TKR, the surgery is easy and the results are good. But you often find very specific implants coming from very specific hospitals, they have good outcomes. Now, when you revise STO to TKR, you use the usual implants. Only you have to use, at times you may have to use a tibial stem to bypass the defect in the tibia. Whereas if you are converting UKR to TKR because of loosening of femoral component in the long term, you might require revision components and thicker polyethylene. This is National Joint Registry of UK. They found that in their population, 47% of people were eligible for UKR, but the usage in the surgeons in UK was just 5 to 8%. What is the reason for this? UKR is not popular in UK from the place where it has origin in Oxford. We don't know. Many reasons are being given. One of the reasons is that the failure rate of UKR is 3.2 times that of TKR. Only high volume centers report equal or better survival of UKR. Now, this situation is very similar to what happened with hip resurfacing. Only Mackman showed that his Birmingham hip had very good results. Other surgeons could not. Probably he had some financial interest, And similarly for this UKR also, people are reporting like that. One of the reasons is that high volume surgeons have better knowledge. They can select better, they select patients in a better way and perform surgery in a better way. So the solution to this is that you increase the use of UKR so that you become a high volume surgeon for UKR. You can select the patient in a better way and perform the surgery in a better way. But to increase the usage of UKR, you have to lower the age threshold for which you are doing the surgery, because the incidence of osteoarthritis is fixed in the population. So when you lower the age, you have young people with UKR, and these people have increased activity, and with increased activity, you have high failure rate. So it is catch-22 situation. We don't know what's the correct answer. Now, when I presented this talk in one of the meetings sometime back, one of the person's audience said that the recovery is faster in UKR as compared to HTO. And that is why he prefers UKR in urban ladies. Now, let me give you a surprise. This is a report which says that the mean time to return to previous profession and mean time to return to sporting activities was lesser in HTO as compared to UKR. So that argument also fails. So in all the aspects, HTO scores over UKR. Another thing is you can do knee replacement bilaterally at the same setting, but you cannot do HTO. I have done it, and the literature also shows that you can do. The only thing is you might have a need for blood transfusion when you're doing a bilateral HTO. Another argument that HTO can cause patellofemoral problems because the height changes. Though the height changes, but there is no clinical problem with the HTO. Even the West is agreeing now. Now you have a UK knee osteotomy registry. This report came in 2015. So the whites are also agreeing that HTO is not bad. It is not for the poor people. It is good for rich people and whites also. Some people say that the HTO benefit is unpredictable. You don't know who will improve and who will not. So first of all, this statement is wrong, but even if you want to be sure, you can use a temporary unloading valgus producing knee brace. If the patient feels improvement, then HTO will give a very predictable outcome. Additional benefit of HTO is that the gait improves because your varus is converted to valgus. Your spinal alignment improves in the same way. And the ankle osteoarthritis also improves if it is there because of the same reason. So when to choose between HTO and UKR? This report said the HTO is more appropriate for younger, though you can do it for older people also, but UKR is definitely not good for young, it's only good for older patients. Another reports HTO you can do for less than 60, you can do for old also, but UKR only for people who are older than 60 years. Now, this is a combined data from Australian and Swedish knee registries, which says that patients who underwent UKR at the age less than 65 had a very high revision rate as compared to people who had UKR at 65 or more than 65. So you should do UKR at a higher age, preferably 60 or 65. So when you compare HTO and UKR, you can do HTO at a younger age. You can do HTO in presence of ACL and PCL deficiency, but you cannot do UKR in that. If there is a varus up till 15, you can do HTO, but UKR you can do preferably with varus of only 0 to 5. Outcome is good in both. Activities unrestricted in HTO and restricted in UKR. Recovery is faster in HTO, slower in UKR. Bilateral is possible in both. Failure of both the procedures need TKR, but revision to TKR is easier in HTO with better outcome, and it's more difficult in UKR with poorer outcomes. So what does an orthopedic surgeon decide for himself? You know, many of them got HTO for themselves. They did not lack any knowledge or information. They did not have any money problem. and they had access to joint replacement services also, but they decided to have HTO for themselves. So what do you want to be? You want to be a typical Walmart customer who goes for the most prominently displayed items and buys them even if he doesn't need them. It is something like getting a knee replacement done. Or you want to be a well-informed Walmart customer who goes for the best deal, and the best deal is high tibial osteotomy. So to conclude, HTO gives good outcome in medial OA knee. HTO is no way inferior to UKR in any parameter. And one of the reports said that the HTO should not be underestimated by orthopedic surgeons under pressure to perform arthroplasty operations. Thank you very much.
Thank you, Ravi sir. Now I will like to request our panelists, Dr. Akhilesh Yadav and Dr. Ganesh Singh, for any queries. And Dr. Akhilesh. Dr. Akhilesh, you are mute. You are mute.
Okay. Thank you, Dr. Puneet. Thank you very much for inviting me as a panelist. There is one question for the HTO, like as in UKR, there is indication that there are contraindication that if there is no ACL or inflammatory arthritis or two things, so we should not do the UKR. But in HTO, if there is any deficient ACL or having inflammatory arthritis, we can do that.
You cannot do HTO for inflammatory arthritis, because if you have inflammatory arthritis, it will definitely go on to the other compartment also very soon. For ACL deficiency or PCL deficiency, you can change the slope and do the HTO.
Okay, thank you, sir.
Ravi, your statement about the HTO, if you compare with UKR, that I feel that is right. But HTO and TKR cannot be compared.
I agree. You cannot compare because
compare with the unique
indications are different. Yeah. Indications are different. But if somebody is doing TKR for isolated medial compartment arthritis,
it should be avoided. We should treat them either. I am very clear. Either they should be treated conservatively, or once all compartment when involved, but activity of daily living is very much affected, then we go for TKR, no UKR. I believe that I am also in the favor of in these conditions. So HTO.
I could find only one.
HTO cannot be substitute where TKR is required.
Yes, for bicompartment disease, you cannot do HTO. For tri-compartment, you cannot do HTO. You have to do TKR. It is only for isolated medial compartment osteoarthritis.
Where UKR is done. Yeah.
Yeah, you have overlapping set of patients. You can choose for both. I argued for HTO.
Yeah, I agree.
I think we should proceed for our next talk. Before further discussion, Dr. R.B. Kalia sir, who will talk on UKR in moderate arthritis knee. So it will help us in guiding which will be better for.
Good afternoon, everyone. After an exhaustive discussion by Dr. Ravi Mittal, I feel my talk would look like a little watered down because I never knew I had half an hour. Anyhow, for the small subset of patients which walk into a public hospital, UKR is also a good procedure to consider. All patients have different perspectives, and probably in my practice, if I see some cartilage behind, I would do an osteotomy. If I don't see any cartilage, I would be forced or probably choose a UKR. So my learning objectives are: what are the current indications of unicondylar knee arthroplasty, and what are the investigations required for deciding this, how to do a good preoperative planning, and some of the technical pearls that I have learned. So why unicondylar knee? Because we have a growing trend of osteoarthritis in young population, and most of my practice is less than 65. And surprisingly, we find large number of our patients are between 50 to 60, especially the ladies. And probably it is an underkill to say that it is single compartment involvement. It is often, even in the earliest arthritis that you operate, you will find that all the compartments are involved to a lesser or greater degree. You may or may not be able to discern it clinically, but often all the three compartments are involved. However, one compartment may be involved primarily. So 1/3 of knee osteoarthritis involves only a single compartment or primarily a single compartment. And those are the small subset of patients probably who would benefit from either a unicondylar or an HTO. Between the lateral and medial compartment, lateral compartment is isolated or predominantly the lateral compartment is only 10%. It is because most of our knees are in varus, and unicondylar in lateral compartment is technically more challenging, and probably an Oxford knee is a very wrong choice there. And so it is performed even less frequently than medial unicondylar, and probably if you are doing a lateral, you have to be in a very specialized center with a certain amount of experience behind you. How do you compare between median and lateral? The results are pretty similar, but the selection of patients needs to be very careful, and you need to have a thorough understanding, and there is a difference between the two sides. So between a unicondylar and a total knee arthroplasty, the argument is probably there's more natural feeling knee in a unicondylar arthroplasty because you are not sacrificing the ACL, the PCL, and the proprioception. And most of our Indian knees are probably in a little varus. So you leave it in a little varus and the kinematics are retained. And the same, if you look at the comparison between unicondylar and total knee arthroplasty, it has got similar patient-related outcome. So there's not much to choose between them. However, you need to be careful that the arthritis should only be limited largely to the medial side. So only roughly 10 to 15% of patients are eligible for unicondylar knee, and these received unicondylar. Rest were deemed to be sufficiently advanced for total knee arthroplasty, and our experience is pretty similar. Probably only 5 or 7% of our patients which come to a public hospital are candidates for unicondylar knee. So between total knee arthroplasty and unicondylar knee, I think the argument always would remain, and you can have evidence from both the sides. However, if you look at the pros, you will see that the unicondylar knee is obviously less invasive, and you preserve a large amount of the knee behind. And since it is a smaller operation, so the complications are less, and if you do it perfectly, the rehab is very quick. And the revision surgery after a unicondylar is more often than not pretty straightforward, but yes, sometimes you do require specialized components. However, it is like a very specialized procedure. The margin of error is very small, and if you err, you're going to land up with a revision very quickly. And the problem with the unicondylar is that the progression on the other compartments is possible. Total knee arthroplasty is well established. It is pretty straightforward, and nobody goes around and revises the total knee arthroplasties till they have not failed profoundly. And obviously, since all the three compartments are replaced, or at least 2 of them are replaced, there won't be any progression of osteoarthritis. It is more invasive. The rehab is slower, and obviously the restriction of activity is much more, and the mortality rates are also higher. So between the two, for a very early moderate arthritis, probably unicondylar knee arthroplasty is the choice that we should be making rather than a total knee arthroplasty. The famous Cosin and Scott contraindications. It was a very early work in the early 90s, and the patients under 60 years weight more than this, having patellofemoral arthritis or heavy workers. And this was unfortunately based on fixed bearing implants. And according to the words of David Murray, which I find very interesting, is if we adhere to these contraindications, then only 10% patients are appropriate. However, if you ignore them, then probably 50% are appropriate. So Poserior Scott's contraindications don't stand now. What the initial criteria were that it has to be isolated, it doesn't stand, and the patellofemoral arthroplasty is arthropathy is not an absolute contraindication. Obviously, you usually do find some amount of indication that there is some amount of arthritis in the patellofemoral joint. However, the mechanics usually do improve after the unicondylar knee. You should not have any lateral joint tenderness. That even currently people agree. ACL deficient knee is an absolute no-no. You can't do it for non-inflammatory arthritis, and BMI is no longer probably a contraindication. And the indications have also got stretched. It is probably a little bit more varus is acceptable, but the important thing is that that varus should be correctable. And I think that is the most important thing, that the clinical exam that to show that the varus is correctable is a very important step in choosing a unicondylar knee. And it is successful even in younger patients, and even the flexion contractures and the range of motion have become less stringent, and sometimes the flexion contracture of about 15 degrees is also acceptable. However, probably a good choice would not be at 15 degrees. So in our practice, we don't do it for flexion deformities. Yes, we are a little wary of flexion deformity, but as far as varus is concerned, we don't have an upper limit of 5 degrees anymore. So the current indications of unicondylar knee arthroplasty are similar to and overlapping to high tibial osteotomy. A bone-on-bone probably is a place where I would not put my money, especially with the high tibial osteotomy. And a retained full thickness of the lateral cartilage is extremely important, so that you should have a perfect lateral side, and a competent medial collateral ligament and the ACL are important prerequisites. Patellofemoral joint status does not matter so much, except in cases of bone erosion and lateral grooving. So you should be careful about doing a unicondylar knee in patients with bone loss and lateral grooving. Frontal deformity, flexion contracture less than 15 degrees. So it should be moderate. You know, most of our patients which come to public hospitals at 30, 35 degrees, 25 degrees of deformity, and those are not good candidates for surely for unicondylar. So the next question comes is, do you factor in the patient's age, what body mass index, activity level? Probably around 50 years, it works better, and it does not influence outcomes. Obesity is no longer a contraindication. However, BMI above 35 is better than total knee arthroplasty. And return to activity after unicondylar is pretty brisk if it is done perfectly. The biggest reason why people don't do a unicondylar knee is the higher revision rate. Now that revision rate is probably because of many reasons. So a total knee arthroplasty has a 10% chance of revision, and a unicondylar has a 60% chance of revision. Why so many revisions? Revisions because when a patient with a unicondylar arthroplasty comes to you with any kind of complaint, the first thing that comes to your mind is that this is failing. So the threshold for revisions is lower, and it is more straightforward surgically, so it is more likely to be performed. So once a patient with a already with the total knee arthroplasty comes to you with a slight amount of pain in his knee or some feeling of mild instability, and you check him up and you see it's reasonably well, so you won't go and revise it. However, unicondylars are prone to revisions. Then the other reason for revision is that the lateral osteoarthritis progresses over time. And then sometimes the bearing spins off, or the bearing fails, or the bearing wears off, and the bearing needs to be replaced. And it is an understatement probably to say that a unicondylar to total knee arthroplasty is a simple procedure. It is fraught with difficulty, yes, but more often than not, if there is no huge loosening of the implants, it is pretty straightforward. However, always remember that when you compare it with a total knee failure, total knee revisions are far more complex than a unicondylar revision. So this is a case example. She is 52 years old, bilateral pain for 8 years, difficulty in weight bearing, deep tenderness present medially, ROM perfectly fine, Oxford mu score poor. Special tests, patental grinding is positive, valgus varus is negative, correctable varus deformity is there, and the ligaments are fine, and there is no knee locking or hyperextension. So this is a pre-operative radiograph, and what we have already been told by Dr. Ravi Mittal, both the possibilities are there. However, when we look at the Rosenberg view, we find that it is bone on bone, and that probably is the clinching argument that an high tibial osteotomy in this lady would not be a great choice. And this is a gate video. So I'm sorry, it's not working. So why unicondylar knee? Because there's bone on bone, there's no arthritis on the lateral compartment, there's a correctable varus, and the ACL is competent, and there's a clear lateral gap on valgus stress view. So this is the kind of templating we do. We do a digital templating. We take time and patience to do this. On the AP view, we check for the tibial component. On the lateral view, we check for the femoral component. And then this is the post-op radiograph. And once we have done the surgery, we analyze the whole thing very, very carefully, what we have achieved. And we have very narrow parameters in which our implant should be lying. And if you can be so accurate, then probably you will have a good results on your hand. Post-op rehabilitation is pretty straightforward. Bedside sitting can be started on day 1, and full weight bearing can be started as soon as the pain becomes less. And this is a post-operative gait of a patient who is walking on day 7. And to conclude, the benefits of UK, probably shorter hospital stays, higher functional patient outcomes, PROMs, which is debatable. There is definitely a lower risk of mortality. Since it's a smaller surgery, chances of cardiac events and fatal venous thromboembolism is less. They require less opioids and lower likelihood of readmission. And most of my patients recover pretty fast within 3 to 4 weeks. Thank you very much for a patient here.
Now the talk is open for discussion.
Ravi, what do you have to say?
Dr. Kalia, I would agree with everything that you say except one. That bone and bone on X-ray is a contraindication for HTO. I think this is a very, very wrong message which is spread around by arthroplasty surgeons. Everywhere in the world, people are doing HTO on bone. The patient, all our patients that we do are bone on bone, and we are doing HTO for them, and we had good results. Literature also says there is no contraindication. I think this is a myth. This is a misconception, wrong notion, and it should be stopped once and for all. That bone on bone, if you have, you should do not do HTO. The choice remains between HTO and UKR. You may do anything, but it is not a contraindication for HTO.
I have a question.
Yes.
Do you add a cartilage procedure for the patients who have bone on bone, do an arthroscopy or microfracture or something, or you don't bother about it?
I have done, and I do microfractures on both the sides, and I have not shown here the pictures. If you want, all these slides were hidden because of constraint of time. I can show you even now. I do microfracture both on the medial, on the femoral and the tibial side, and it is always. See, our patient will not agree for the surgery unless it is bone on bone. They will never agree. If the cartilage is intact, they will never agree for the surgery. Even HTO, even simple surgeries. It is only when there is bone on bone and there is severe pain, and then only you can see the joint space reduction, and then only will they agree for surgery, because medicines are not working for them.
Ravi sir, what is your opinion regarding uni, sir? This patient is not fit for or good candidate for the HTO, and will do better with uni. And the same question from Kalia sir, ki this patient is not bad, good for uni, can perform better with HTO, sir. From both of your sides, sir.
Excellent question.
See, my answer would be I don't do UKR, so I believe in HTO, so I don't do UKR at all. So I do HTO for everybody who is good candidate for HTO. And the same would be for if the same patient goes to somebody else, he would like to do UKR. So it's a personal choice. I do HTO only. I don't do UKR.
My take on that would be probably that it's like an overlapping kind of indication. And since I do both of them, so I choose little wisely, probably. And for a patient who is probably less than 50 years of age, or 52 or 53 years of age, I would choose a unicondylar knee. Sorry, I will choose a high tibial osteotomy, but I would always be adding a cartilage procedure on it. And I will be doing an arthroscopy. For a patient in the Indian scenario, that 65 age is mostly for the Western kind of a thing. For our patients, that we see very young arthritis, right? So my take on that would be around 55 if I have a patient. I would not be choosing an HTO. I would probably be choosing a unicorn. Now, that's a very statement which doesn't have a lot of evidence behind it, but it does make certain amount of sense in my practice. I do both the procedures. So I'm comfortable doing an HTO. I'm comfortable doing a unicorn. So probably this is my thought about it. And it is absolutely my thought. So I can't, give any evidence behind it.
Dr. Ganesh, would you like to say anything?
No, sir. Actually, owing to the literature that there is no consensus on ideal method of treatment. So there are various treatment options available to us. I think the crux of the matter would be the success of the procedure will be choosing the right patient, as told by every one of the dignitaries.
Exactly.
Choosing the right patient and right technique and surgeon experiences, all these are variables.
But one thing that is very revealing, what Ravi Mittal says, that HTO can be done in bone and bone situation. That is, we rarely heard. So, and he has, I have seen his result. I have worked with him around 15 years. So when I was in AIIMS, I used to send these simple cases like uni compartment early and not responding to the conservative line of treatment. Then I used to send him, and really patients were happy. That my observation when I was at AIIMS.
Ravi sir, did you face any problem in varus valgus instability while doing HTO, because MCL becomes very much fragile after HTO? And is there any change of implant if we are converting HTO to TKR in that situation, sir?
First question is varus and valgus instability.
Yes, sir.
No,
because
you're doing osteotomy way below the joint line. So you're not touching the deep MCL at all. You are only erasing the superficial MCL. And you also do the same thing while doing a TKR. You erase the superficial MCL and you maintain that soft tissue sleeve. And you don't get any varus valgus problem after HTO. Even I cut the superficial MCL transversely. Okay. No problem. Because my deep MCL and posterior oblique ligament and posteromedial fibers are all intact at the joint level. I'm operating way below the joint line. So we are putting 4 screws in the proximal fragment. So there is no problem in the varus valgus. I have not converted HTO to TKR till now. Probably if my cases fail, they will not come to me. They go to somebody else. So I didn't have a chance to convert my cases or any HTO to TKR till now.
Okay, sir. Thank you, sir. So I think we should proceed for the next talk to Dr. C.S. Yadav, sir. TKR in difficult knees.
Yeah, this will not be a talk. It is a case presentation mainly. So everybody will be involved in that. It is for difficult case, interesting cases. Because I came to know this topic just late night. So I thought in this scenario, I should present different cases, which today evening I could collect. So I will share these cases with you and everybody will be involved in that. So first case, non-union tibia upper end more than 20 years with osteoarthritis. Now I am working in the Primus Hospital after working at AIIMS and Sir Gangaram Hospital. Sorry. And this is the scenario. 60 years, non-union, more than 25. Now patient have problem in carrying out the activity of daily living, and he has significant pain as well. So problem, many issues, skin, soft tissue conditions, proximal fragment. This is also issue. Non-union is the issue. Then what do you think, what has to be done? Dr. Kalia?
Sir, I think basic problem here is non-union. So I would be treating the non-union first.
So no, then we will go for the replacement. Huh? It is like that.
Probably, if you look at both the joints on the lateral view, I see a pretty fine, reasonably decent cartilage.
Yeah.
So I would not be choosing a joint replacement in this patient. In my hands, I would definitely be going for an internal fixation and try to fix his non-union, which is probably the reason why he has so much of disability and difficulty.
Previously, it was also tried. You can see the multiple surgery was done. This is the scar. Here is also a scar. So we do not know why it was not uniting. Maybe some poor fixation, fragments might be moving, so may not be solid fixation. So Dr. Akhilesh? You are mute.
Yes, sorry. Sir, I think you're right, because patient already went through a lot of surgery. As we can see in the pictures, he is having the multiple scars, loose skin, grafting. So there may be reason for the non-union, and that's why everybody has tried their own. So now it is limit now. So we should think of the other things apart from try to unite it.
Mm-hmm. Like
I would like to go for the hinge prosthesis, because he is 60 years having non-union. So we can go for the tumor prosthesis also.
So hinge here, I think ligaments are intact. So hinge is given for the situation where you don't have like medial sleeve is significantly incompetent, or then you can. But I think ligaments are intact. Then what is fun of giving hinge over here? Problem is non-union and this proximal fragment, this small proximal fragment.
But we can see that there is anterior, proximally anterior half of the tibia is non-united, and it is displaced anterior also, and ligaments are maybe, and they are attached with the medial and lateral on the lateral is on the fibula. So no doubt the sleeve is intact. So we can, on the table we can decide it. We have to be everything in the OR. Yeah. If everything is fine, so the ligament are fine, then we can use the sleeve also.
Can we sacrifice this proximal fragment and put it like proximal tibia replacing, like tumor surgeon do like that replacement?
Sir, if the ligaments are okay attached to the tibia and on the fibula, so we can compromise this anterior fragment and we can go for the sleeve and the stem.
So no tumor processes, huh? We can go for like Noyle's sleeve. Huh?
Yeah, I can think, but we have to ready for everything in the OR, particularly in these cases.
That is the best for the surgeon. Always what I feel, keep ready everything and take your intraoperative decision.
Right.
Do not be fixed ideas on the basis of CT, MRI, clinical examination.
Exactly.
While you are operating, intraoperative examination and feeling. If you are a good surgeon, there are two weapons for the good surgeon. Eyeballing, should be very good at eyeballing. And second, feeling during the surgery, what you are feeling. If you have two good sense, then surgery is always successful. Dr. Ganesh, what do you say?
Yes, sir. I very much, my thoughts are very much similar to Akhilesh, sir. Dr.
Yeah. मित्तल साहब, तुम क्या करोगे?
ये तुम्हारे पास ही भेज देंगे.
Now you are doing a lot of orthoplasty. I know that. You are doing especially knee replacement. You are doing a lot of knee now. So
if I have to,
though you will send to me, I agree. But I know what you plan, what you can do.
See, first of all,
नहीं करो आप.
The tibial.
आपको पता होगा कि इसमें ये होना चाहिए.
The femur cut is as usual. For the tibia, I'll use a intramedullary jig to just cut, and probably a temporary plate.
Excellent, Mittal Saab. Intramedullary tibia, which we usually take external alignment jig. Here, intramedullary is the main key point. और बताइए, what do you say further?
And if the fragment is very mobile, then I'll use a temporary plate, which I can remove after putting the implant with the stem. बाकी कुछ नहीं.
अच्छा.
As usual.
This is the patient is standing. This is the situation, and this is so we have option, either we go for orthodesis or arthroplasty or tumor processes or constraint processes, like Dr. Akhilesh was mentioning, and less constraint processes. So it should be decision should be during surgery. Where I always decide during surgery. I go with the provisional idea कि ये करना है, शायद ये होगा. But decision may change little bit here and there during the surgery. So intramedullary cutting of tibial cut, that was the most important key point. We decided that we will use intramedullary alignment guide, so our this proximal fragments gets stability while we taking the cut, so it doesn't unstable toggle when we are using saw over the this small proximal fragment over. So main that leading factor, intramedullary alignment jig, and which we have used, and we came out with the just CR implant. Femoral cut as usual, tibial cut with the help of intramedullary implant. You can see fracture over there, here. And this is post-operative X-ray. This is patient is standing, and this is patient is from Faridabad. Now it is more than 3 years. So we did CR knee in this case. With only one point was there, intramedullary jig should be used in this situation to take proper tibial cut. And you should also, because ligaments were all intact, and we got excellent stability just with the CR implant or deep disc CS implant.
Wow.
So that another case.
Yadav, you also talk about the plate, small plate that you have used.
Yeah. It is there, a small plate. Yeah.
Because you have to, the stability is also required while you are inserting the implant, because the fragments will toggle when you are putting the implants.
Yeah. So we put plate later on. Implant was sufficiently stable with the intramedullary rod, that cutting alignment jig. So, and we should also have good control over the saw. जब सॉ चलाते हो तो आप फ्रैगमेंट को कितना हिलाना है आपके हाथ में. अगर आपको चलाना नहीं आता है तो ऐसे ऐसे फ्रैगमेंट, और सॉ भी ऐसे भागेगी, फ्रैगमेंट भी ऐसे भागेगा. You should know how to push it and how to push forward, how to trigger, how to press the trigger, how much. So if you push the trigger very much, it will toggle. So you have to be little gentle while pressing the trigger and pushing the fragment saw. So you may take little like a few seconds more to take this tibial cut. So another patient. So issues, bone defects, we do not know about the ligament, and lots of osteophytes everywhere. So what to do? Dr. Kalia?
Probably this one would require a semi-constraint. So I'll be ready with at least a semi-constraint, and I will be building up the tibia. So there's a tibial defect which would require bone grafting and a couple of screws.
Yeah.
And I would try to do with the minimum possible constraint possible, but I would be ready with the semi-constraint in this one.
We should be ready. Definitely, we should be ready with that.
So, sir.
Akhilesh?
Sir.
Akhilesh.
Yeah. So, sir, I did 4 cases like this. In that cases, because I used Rapio implants, so I did all the primary things. I used primary implant, except I used the medial wedge in the tibia and stem. So it was easily done, and only 8 mm poly was used in all cases.
Take minimal cut.
Yes.
Take minimal cut.
Yeah.
Dr. Ganesh hai? Dr. Ganesh is there? No. Ravi, what do you say?
I think we can do the usual implants. At the most, tibial stem. Will bone graft on the medial tibial condyle if required. Otherwise, reduction osteotomy will decide either no graft or screw with cement or just a plain tibia. So after taking the tibial cut, we'll decide.
What about the constraint? How much constraint?
Usual constraint, CR knee. CS. I do CS.
You do CS like me.
Yeah, I do CS.
Chandrasekhar, CS. So these are the intraoperative photographs. He is relative of my wife from Haryana, and we came out just CR implant and without putting any base, because what we did, we downsized the tibia. We were having modularity of 2 sizes and lateralized the maximum possible tibia. Okay, so you can see we were having almost full coverage of our tibial tray. Almost full coverage. So because of downsizing, lateralizing, and just CR implant, which I do in each and every cases of primary. So we use little thicker insert because we try to get more surface for the tibia. So it is 14 millimeter. Okay, it is like a 13 millimeter. It is a triathlon. What I feel, it is a triathlon. So it was the 13 millimeter. Yeah. So we came out with no extension rod. I have seen extension rod is misused, overused. When you downsize the tibia, lateralize the tibia, no need to use most of the time you get good tibial coverage. So even no need to go for the reconstruction, or even no need to have wedges and extension rods. So you can see almost whole tibia is covered, and this lot of osteophyte be removed. With this much osteophyte be left, because if I would have removed this, my medial sleeve might have compromised. So deliberately, it is not always necessary कि सारे osteophyte निकालो. When you think removal of all osteophyte is necessary for the balancing, remove them. Sometimes if you कई बार आप ज्यादा कि नहीं ये तो osteophyte है मैं निकालूंगा ही निकालूंगा, in that case you may damage medial sleeve. So avoid taking out all the in this situation all the osteophyte which we have left over here. You can see here it is some sort of osteophyte. So another case, uni बहुत fail होते हैं, इसमें कोई शक नहीं है. I am revising many unis. Even I have revised uni from big high volume surgeon from North India, and I have revised bilaterally failed uni surgeon from Noida. And Ravi knows all these things. So what do you say? How would you proceed in these cases? Uni implant removed. Now, what will be implant, and how much it will be constrained, whether wedge will be required or not. So these are the issues, constraints of the implant, wedge will be required or not.
So as a rule, we have to ready with all the things.
Yeah, I agree.
The augments, the augment. So I think it's not a very much complicated like the other cases you have did.
Yeah, I agree.
So it's a simple, we have to be ready with the stem and augments and the step.
Dr. Kalia?
Revising a unicondylar is not to be taken lightly. It is not a straightforward thing that you're revising. You have to be ready with all kinds of implants, even with a slightly higher constraint as well. And it will all depend on the tibial cut. If you take a tibial cut and you're left with a very small, probably a 1 or 2 millimeter defect on the medial side, you can probably get away with just a stem. But probably even with the maximum possible tibial cut on the lateral side, you have a large defect on the medial side, then you need to augment it. And probably a stem on the tibial side more often would be my choice. Rest, the femur is pretty straightforward, so it's not the problem on the femoral side more.
Yeah. Ravi?
See, everything will depend how you remove the implants. If major bone loss is there while removing the implants, your plan changes. If there is no significant bone loss while after removing the implants, then it's a straightforward revision to TK.
Now I will show what we have done. We have taken all femoral cuts. We have taken a tibial cut. We have done broaching.
So you remove the implant first.
हाँ, implant first. तो बिना implant remove हुआ हो जाएगा?
क्या पता आप कर दें?
We removed all but with full precaution, without damaging further bone. So we go in between the implant and cement interface, not between the bone and cement interface.
Okay, so what instrument do you use?
Fine osteotome, very fine, and very fine. जो 100 blade आते हैं ना, उसमें भी कुछ thicker आते हैं, कुछ thinner आते हैं. You might be knowing. So very fine osteotome or that very thin saw blades.
And for femur?
Same is for the femur. Small bit and multiple. We go in between the implant and cement interface. We push it gently, but you have to be gentle. Multiple small blow. Starting from this area, go down up to the posterior. Okay, similar is over here. So we removed, as you see, we have damaged minimum bone, further bone. You can see cement is still over the tibia. You can see, as you told, kam se kam bone ko damage karo. Our this cement is still over the tibia. It means we have not damaged the bone. Okay. So what we have done, all our preparation, all our bone cuts. So once again, we came out with the just CR implant. And this is Mossy of that bariatric surgeon from Himachal, Mossy. It was operated in Chandigarh. And so we revised it with the just simple minimum constraint. Another case, rheumatoid valgus knee with implant in situ. Now, what to do? What will be the, it is a valgus knee, what should be the approach, which implant should be used, and what should be the other considerations? Ravi, how would you proceed?
I think you showed this case previously.
Yeah.
The tibia cut is usual, femur is by eyeballing.
Femur?
Putting the extramedullary image.
Yeah, extra. तो तुम्हें
So,
पता
I
है,
know
तुम
this
रहने
case.
दो.
Don't ask me. I know this case.
तुम्हें पता है, तुम रहने दो फिर. Dr. Kalia?
I see a lot of medial joint opening.
Yeah.
And that means that probably my medial ligaments are not working. And probably for this patient, computer navigation would be a good choice. And probably a semi-constrained kind of an implant. But on the femoral side, with this implant I will have difficulty in my cuts and everything.
Yeah, definitely, because implant is there.
Yes.
Or patient was also not very good general condition because of long rheumatoid and some referral of DG Haryana. Then Manoj Yadav was DG Haryana, known to him. So Akhilesh, what would you do?
I think we have to be, I mean, on the right side.
हमारी आवाज स्प्लिट कर रही है, probably internet connection.
Hello.
हाँ, आवाज स्प्लिट कर रही है, डाउन.
Hello.
हाँ, बोलो.
Okay, so on the right side, I think ligaments are fine on both the sides. I mean, there is no problem with that. I think I would go simply. I mean, I would keep the stem and augment, but I think I can manage with the primary implant.
Yeah. So what we did external, we don't have navigation. Even in this situation where we have not removed the implant, we always use external alignment method like tibia. We first mark the hip center, then mark the knee center, mark the sulcus that of the femoral condyle, and we take cut 90 degree to that, and cut should go through the deep sulcus. So it is almost around the 8 millimeter thickness. So this is our cut without navigation. And this is figure of 8, which is formed over the distal femoral condyle. And this is post-operative. You can see. And this is once again just CR knee. No VAS, no extension rod. Now it was done at Gangaram Hospital. We have 3 years follow-up. Just simple CR triathlon. Without navigation, just external alignment method. First find out the hip center, mark it, then put a rod from the center of hip to the center of knee, then take a cut 90 degree to this rod, mark from the that ink. So we have done that, and it is an excellent thing. So it can be done even without navigation. If you have navigation, another case we did at AIIMS, old case, and we draw by that distal femoral cut. So you can see it is at the almost 90°, and we took this. This is a different patient. So you can see you can come out with the very excellent accuracy even without navigation, if you know how to play with the external alignment method. You can see, and we find out this distal femoral cut. It is at the almost 88 degrees. So between 3 millimeter of error that can be excused. So external alignment, there is no need to remove implant in all the time, require another incision, and it may weaken the bone, and constant knee with extension rod, and so it is like that. Another case, this patient, some director of ESI wife operated, I think 1 year back. This is the X-ray. This is the valgus or varus strain. So patient is fine. She is walking, but she has some feeling of fall or instability, especially in certain postures. And on X-ray, everything looks fine. Even valgus, varus instability is not there. MCL is intact. But patient is not happy. डॉक्टर साहब मैं लगता है चल नहीं पाऊंगी, कभी-कभी लगता है गिर पड़ूंगी. ऐसा पेशेंट बहुत आते हैं कि एक्सरे ठीक है, क्लिनिकल एग्जामिनेशन भी ठीक है, बट पेशेंट खुश नहीं है, उसको कॉन्फिडेंस नहीं है चलने का. What to do?
Sir, I can see on the valgus view, there is instability medially as well. There is opening up on the medial side. So it is a varus valgus instability, and you have to revise this knee. There is no way this instability will go by any other method.
बहुत ज्यादा ओपन जब कुछ होता है ना डॉक्टर कालिया, बहुत अगर MCL और LCL इंटैक्ट नहीं होते हैं तो पूरा जोड़ लगा के इतना खुल रहा है ना, जोड़ लगा के, तो it is not too much.
Laterally it is opening by more than a centimeter, and
lateral वैसे भी lax होता है.
7 millimeters.
Lateral is most of the time it is lax, but even the natural knee. And if lateral laxity is there, patient doesn't feel much insecurity. Most of the insecurity comes when medial sleeve is not intact, medial instability is there. So medial,
I feel the valgus. Yeah, there is something going on there. So it requires a very careful.
Medial almost it is good sleeve is there. Even after the thrust, valgus thrust, it is not opening up. You can see hardly any opening up. Lateral, what I feel is always little laxity is there, even in the natural knee.
But only a few millimeters is acceptable. This is much more than that.
So but this is totally imbalanced.
Yeah.
So what जो सर्जन होता है ना भाई खोल के देखते हैं. मैं तो बहुत जल्दी, मेरा नी को खोलने का थ्रेशोल्ड बहुत छोटा है. अगर कुछ समझ में नहीं आ रहा है, let us see इंट्राऑपरेटिव, और इंट्राऑपरेटिव दूध का दूध पानी का पानी हो जाता है. जब टेबल पे आप खोल लेते हो, नी आपके सामने पड़ा है, then you can make out very easily. So we found this बाद ये कटारिया साहब हैं ESI के बॉस, उनकी वाइफ का ये. This plastic was broken, insert was broken. We changed the insert. She is perfectly happy more than 6 months. She is both are very grateful to us. हमने उनको बताया तो पूरा रिवाइज भी करना पड़ सकता है, लेकिन पहले हमने बोला था कि शायद देखेंगे अगर इंसर्ट चेंज करने से काम चल जाएगा कटारिया साहब तो वो करेंगे. और हम we were shocked and surprised. We never thought कि insert will be broken.
What was the duration of the first surgery?
Less than a year. not very
Sir.
long.
So do you see this breakage often?
So I also did.
इसलिए तो it is not, but थोड़ा सा कुछ उनको fall की history तो थी. एक बार मैं कहीं झटका लगा था, मैं गिर पड़ी थी, वो history तो थी.
नहीं, वो तो ये प्लास्टिक के टूटने से भी हो सकता है.
It is not very often. So मैं instability को clinical पे भी कुछ नहीं मिल रहा था. Mid flexion and full extension से लेके 90 डिग्री तक I was feeling knees looks quite stable. हमने व्यू भी कराए. व्यू में लेटरल ओपनिंग थोड़ी सी एक्स्ट्रा थी, बट लेटरल ओपनिंग को आई डू नॉट गिव टू मच वेटेज. मीडियल ओपनिंग को मैं पूरा वेटेज देता हूँ. सो वी ओपनड इट एंड वी जस्ट चेंज द पॉलीएथिलीन and she is.
So I also did.
We did nothing, just change the polyethylene. And polyethylene mein what we did, we put that deep disc. Here it was not deep disc. Previous, you can see it is almost flat insert. It is from Smith Nephews, I think. इस समय मंगाया था. So it is flat insert. So it is a deep disc. ये आगे elevated है पूरा. Even borders are little bit more. This middle they are elevated. So we just change the insert with the deep disc and more thicker, and she is fine. Now it is going to be more than 6 months, around a year. It was done in new hospital, Primus Hospital. Yeah, Akhilesh कुछ कहना है? Akhilesh तो बार बार म्यूट हो जाता है यार. बोल बोल. Dr. Kalia?
Sir, I'm quite surprised that you didn't get any instability just by changing the plastic. If you look very carefully at the preoperative X-ray, the tibial cut is too deep. That is one thing I could see. So just by increasing the depth of the poly, you have taken care of that. Yes, the tibial cut is very deep inside. And I don't know how the medial instability behaved after changing the poly. Since it was like a global instability, there must have been some flexion instability as well. So just putting the poly took care of the medial, the lateral, and probably the wrong tibial cut very deep that they have taken initially. They have put a very large poly initially also. Your poly initially should be very small. So if you've taken a very deep cut, then your poly is large. So a large poly means that you had some trouble initially. And
पॉली पहले की मुझे लग रहा है बहुत ज्यादा मोटी नहीं थी, इसलिए हम जस्ट पॉली चेंज करके ही निकल पाए.
Yeah, but it must have been at least 10 or 12 millimeters already.
It was, I think, 11. We put like, I think, 15 or like that.
Yeah.
It was,
So,
and I am not very familiar with this implant. I do not use it. Just be, क्योंकि already कहीं का हो रखा था, कहीं किसी ने किया हुआ था. तो, but honestly speaking, it was fantastically stable knee on table, and patient is fine. A patient is quite bulky. She is more than 90, near 100.
The only thing is, if a poly is failing within 1 year, there has to be some micro instability going on. If it was perfectly balanced, it would never have failed at 1 year like this with a fracture.
Yeah.
So
एक बार हिस्ट्री है कि मैं सीढ़ी से जब उतर रही तो मैं झटके से नीचे आ गई थी, गिर गई.
That could be after the fracture had happened. So it's difficult to imagine what really happened, but failure at 1 year means something grossly wrong in a knee. It would wear at 1 year, it won't fracture at 1 year.
Yeah.
So there must have been abnormal stresses on the poly.
So another case. This was done at Leh Ladakh. Every year we go there, and you can see this patella is lying over the lateral condyle of the femur. It is absolutely laterally and migrated little superiorly. And you can see it is over here. And here it is over here. So how to go about this case? And this patella is basically not, even after the big thrust in extension, it doesn't comes to the center of knee. It doesn't comes into that trochlear groove. Rigid है, हल्का सा move करता है. If you move it medially, it will move little bit. It is rigid. 20% it is movable, 80% it remains like that. And you can see कितना ऊपर यहाँ पड़ा हुआ है पटेला. Pura femur, this is the femoral condyle. It is just totally laterally and superiorly. So how to go in this case? This we have done in Leh Ladakh. Now we have 3 years follow-up. It was done before COVID.
My thought about this is, first you require a much better radiograph than what you have, because this radiograph is in a lot of rotation, and that could be leading to this conclusion that
हाँ, वो clinically हमने देख लिया था. Clinically और भी radiograph होंगे. मैंने शाम को ही सारे ये फोटो जल्दी से पेशेंट्स के थे डाले हैं इसमें पीपीटी में. So but clinically it was not correctable. Patella totally laterally placed and subluxing, not subluxing, dislocated over here and proximally migrated. Mittal साहब क्या करोगे?
Lateral approach.
Lateral approach. करी है तुमने? Have you done?
Yeah, मैंने नहीं करी है.
Huh? What you know? You are a man with, you know साले theory more than us in ortho, even orthoplasty theory.
नहीं ऐसा नहीं है.
आप लोग मेरे को सिखाता, तू कई बार मेरे को पढ़ाता है. मैंने कहा मुझे नहीं आता, प्रैक्टिकल चीजें आती हैं. So Dr. Ganesh, so should I show what we have done?
Yes.
Dr. Kalia?
Sure, sir, why not?
मैं दिखाता हूँ क्या हमने किया है. So because it was very rigid, और अगर rigid deformity, valgus deformity है and patella like this, so we decided go through the lateral approach. Or lateral approach में if you do not add TTO, you do not get good exposure. Tibial cut और सारे cut आप ले ही नहीं सकते. So we opened from the lateral side of the patella, lateral approach. We did TTO. So सारी चीज आपके सामने पड़ी है. उसके बाद patella इधर है, whole medial sleeve and patella is here. We have already taken all femoral cut. This is tibial surface after the TTO. And what we did once again CR implant in this case. And what after the, इसको पूरा approximate कभी नहीं आता भी नहीं है. Once it is a rigid deformity. But what I feel, I make a scaffold, multiple suture पूरे border पे I put there. I do not tighten them, otherwise patella once again it will sublux to the same place. Just put it there. So some fibrosis may take place over this scaffold. So some sort of implant coverage is there. So and we came out with the just, you can see CR implant once again. And this is the patient. I think video will work.
Yeah.
This is, you can see, full extension. And this is more than, this photo is more than 2 year follow-up. उसके घर से ही मंगाया फोन करके. So we came out with the CS implant, or nobody will believe TTO, lateral approach, and CR implant, what has been taught to our nation, कि मैं constant use करूंगा, TC3 use करूंगा, hinge use करूंगा. और I say, और Mittal is my colleague, he knows that we can come out with the just CS implant. He has seen our cases. We were in the same unit. So many things has been taught wrong to this nation, I have to say. So use minimal constraint in the life. It is good for everybody. So another case, शायद खत्म होगा, last case होगा. Mittal साहब, non-union with, you can say, severe osteoarthritis. What to do?
Intramedullary jack for tibial cut, tibial stem, usual constraint CR.
Excellent. यही किया है. And now this patient follow-up में बहुत दिन से आया नहीं है, but she is perfectly fine. So we use once again intramedullary long rod and all the graft which we retrieved from the cuts, we put over there all around charo taraf. So this is all about 4-5 cases.
Lovely.
Now, in any primary, I do not use PS. Come out with the just PR or DPS. So I think this is all over from my side. Dr. Puneet?
Hello.
Dr. Puneet?
Yes, sir.
So I have done.
Yeah, I think we should conclude here. Dr. Sirohi is here. He joined us.
Yeah, we can see him. Yeah.
Dr. Sirohi.
Sirohi साहब अभी बैठे तो थे.
I think, is there any question or any query from the panelists or other faculty?
Yeah. Any question in chat box? Audience से कुछ?
नहीं sir, और तो कुछ नहीं है sir. So I think we should conclude here. I would like to thanks to Dr. Ravi sir, Dr. Yadav sir, Dr. Kalia sir, Dr. Akhilesh Yadav, Dr.Ashok Shyam sir, our Ortho TV team and all delegates. Thank you sir on behalf of Uttaranchal Orthopaedic Association.
Thank you, Puneet. Thank you, Dr. Kalia. Thank you, Dr. Sirohi, for inviting us. Okay, Ravi.
Thank you. Good night.
Thank you, everyone.
Thank you sir.
Okay, bye-bye. See you soon.
Thank you, sir, for sharing some good cases.
Thank you. Thank you, Puneet.
Thank you.
Thank you. Bye.